Good afternoon. My name is Marie Rienzo, and I want to welcome you to the NIH Office of Disease Prevention's Methods Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar by clicking on the question mark in the WebEx toolbar. Please direct your questions to all panelists. We will open the floor to questions that have been submitted via WebEx at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in approximately 1 week. You will receive an email when they are available. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you will be prompted to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and the Director of the Office of Disease Prevention.
Thank you, Marie. Today's speaker is Dr. Colin Walsh. Dr. Walsh is an assistant professor of biomedical informatics, medicine, and psychiatry at Vanderbilt University Medical Center. He's a practicing internist. He received a degree in mechanical engineering from Princeton and his medical degree at the University of Chicago. He completed residency and chief residency in internal medicine at Columbia University Medical Center. He received a degree in biomedical informatics through a postdoctoral fellowship at Columbia. He joined the faculty at Vanderbilt in 2015. Dr. Walsh's research includes machine learning and behavioral health, including suicide prevention and psychiatric phenotyping, clinical decision support to enable prevention, predictive modeling using electronic health record data, and evaluation of value-based care through data science. It's my pleasure to welcome Dr. Colin Walsh.
Thank you for the introduction, and thanks to all of you who've chosen to join this webinar. So with that, I'll get started. First, I have no relevant disclosures for purposes of this talk, and we'll begin by discussing our objectives for the day. We'll begin by discussing some active efforts in data science for suicide prevention, and we'll make sure to take some time to talk through the methods that are going to ground this talk. Next, we'll talk about some ongoing collaborations to implement predictive models at the point of care, and you'll hear that word collaboration a lot today. Finally, we'll emphasize some of the challenges that are particular to this domain, and not just true for suicide prevention, true for other problems as well. But we'll talk about some of the analytic as well as some of the ethical challenges that we're running into in the course of our work. We'll take a moment to emphasize the scale of this problem. So suicide prevention is really tackling one of the epidemics that's affecting not just the United States, but the world. Today alone, 123 Americans are estimated to die from suicide. Some staggering numbers from the CDC. It's the 10th leading cause of death in the United States for all ages. It's the second leading cause of death for those under 34 years old. And as you can see in a given year, a really significant proportion of Americans are potentially affected by suicide attempts, both fatal and non-fatal, as well as by suicidal thoughts. Suicidal ideation is something you may hear me say in this talk, and by that I'm referring to suicidal thinking and contemplation. As you can see, suicide rates have continued to rise over the past couple of decades, and these numbers bear out of the last 3 years as well into 2019. And one of the themes that you'll see today is that these rates are not static for all age groups. These rates vary depending on which age group we're in. And so one of the take-homes for today, and you'll see this again, is that just like these rates will vary for different groups, one model and one algorithmic approach may not fit all. One of the first steps in suicide prevention is understanding who is at risk. And this is a space where data science currently is seeing a lot of use. The idea of identifying from complex healthcare data, sometimes data that we already have, electronic health record type data, for example, we're able to identify patterns that may give us some sense of who will be at risk in the future. Now, what's unique about not just suicide prevention, but mental health in general, is the idea that these problems are sometimes underrepresented, underreported, or even undercoded in clinical data and healthcare data. For example, some of our colleagues at the Mental Health Research Network published some numbers that were really surprising. Out of 6,000 people who ended up dying from suicide in their system, fewer than a quarter had a mental health diagnosis in their medical record in the entire year before death. A number that makes me jump even more, looking at a primary care study, looking at a number of primary care settings where suicidal thinking, suicidal ideation, was documented in primary care notes, only 3% of the cases in that sample also had a diagnostic code. Now, if you're someone like me who relies on the types of healthcare data that we're collecting every day, for example, diagnostic coding data, those data are readily available and easy to get to. But if the codes don't have evidence of something we care a lot about, it's very difficult, obviously, to use them in prevention. So these are some of the problems that really underline why we're trying to use innovative methods to tackle this problem. Now, how are we able to have a conversation about data science and suicide prevention today? Well, these are not comprehensive themes, but 3 of the themes that I'd like to emphasize for you are going to be covered now. So the first is availability. So there's a wonderful community that's designing tools and algorithms that are readily available through open source community efforts to basically make people like me who may be close to electronic health record data at a hospital like Vanderbilt, we can actually apply those tools on our data. Secondarily, there's a really incredible growing appetite for collaboration really across disciplines to tackle these really challenging problems. None of the work that you're going to hear about today is possible without that collaboration. And finally, thanks to researchers who've been at this for decades in the space of suicide research and suicide prevention, we have wonderful understanding of some of the risk factors and protective factors that precede suicidal behaviors. And we try to take advantage of that knowledge in our design. There are many examples of groups that are working in this space. You're going to hear just about a few of them today. And even this slide that includes a number of logos is not going to cover all the wonderful groups that are working here. And I'm going to touch on a few of these. But the work, for example, being done in Veterans Affairs and the Mental Health Research Network, the Army STARS group, a really terrific group that's one of the forerunners here, and some of our colleagues over at MGH and Partners. And there's a number of groups that I didn't even have time to put here in Cincinnati and Northwestern and more. And that's not including global efforts. So all that to say, there's a number of great communities that are working on this, and it's really going to take all of us working together as a learning health community to work together to really tackle a problem as complex as suicide prevention. So now let's take a moment to talk about some of the methods that are going to drive what follows. And I'm intentionally going to take a fairly high-level view, and in question and answer, if there's particular areas that are of interest, perhaps we can get to those. But let's talk about how we tackle this. So when we're talking about data science and analytics, we'll look at a modeling primer here, just to give you a sense of some of the really high-level steps that are involved. So in data science, just like in all good science, study design is mission critical, and we try to spend as much time as we can formulating the problem we really care about, understanding the outcomes that we are interested in, the cohorts that are applicable, and that's really where we have to work with our stakeholders and our collaborators really from day one to understand what exactly we're setting out to do. That second step there, the data extraction and cleaning, is how do we make the data that we have available amenable to computational studies. And for those of you who spend time in this space, you probably know that second step there is often the one that takes the most time. Next, we start to think through, if we understand the problem we're interested in tackling, what are the potential inputs that may help us define those signals, the predictors or the features that may help us actually predict those patterns into the future. And sometimes we need to transform those predictors in ways that make them more amenable for algorithms. Next, we finally get to prediction and testing or validating those predictions to see if they're finding the patterns that we actually care about. And I'll describe that a little bit more. Finally, I end this slide with iteration. The idea here, again, like all good science, it's an iterative process. So we set out on a path with our best estimate of what we should do, and we often find we need to course correct. So it's important to note that we sometimes will go back even to the very beginning, to the study design step, in order to try again and do a better job as we iterate forward. So an overview of some of the methods that I'll talk about will come from this paper, and I won't go into great detail in the interest of time, but I do want to leave this here in case you'd like to read about them a little bit further. And we sought to be explanatory. My colleagues Jess Ribeiro and Joe Franklin, who are currently at Florida State, and I put this together with respect to our first effort to predict suicide attempts, looking at time as well, using electronic health record data and machine learning. So I'll tell you about some of the choices that we made in that study. I say this often in my lab. I often say that predictive modeling is about choices, and those choices impact a lot of the science that follows. So the first set of choices that we made in that first study were to understand the outcome we really cared about, as well as the cohort of interest. And it's easy to underestimate how difficult that can be. The outcome we sought to define was suicide attempt, measured suicide behaviors in our electronic health records at Vanderbilt, and we used 2 expert chart review to validate those attempts. one of the first findings that we saw, I mentioned diagnostic codes before, diagnostic codes for self-injury alone in our sample did not show evidence of suicidal intent, something we care a lot about, 42% of the time. So that chart review was really important to clarify the signal that we subsequently gave to the algorithms. Next, we thought about the cohort that we wanted to actually run our studies on. And so we started with a fairly simple definition. We wanted the adult population receiving routine care over roughly 20 years at Vanderbilt University Medical Center as our initial cohort. But then we had to define that a bit further. We started to think through the samples that were actually relevant for the problem that we were tackling. So for our first effort, we looked at roughly 3,000 cases of confirmed suicide attempt by that chart review that I mentioned as our outcome signal. And then we did a case control retrospective study to compare them to comparators that we thought were relevant. The first definition we chose were those adults who were receiving routine care for a number of reasons over some minimum number of time and some minimum number of visits. And that's not an unusual choice in this space. But the great power of data science is that we can really define and use the data that we have to define that cohort, but we also have the potential peril of making a number of different choices. And each of those choices is really going to impact the study. And so I always emphasize that point. We could have said, and actually did in this particular paper, we also did a comparison to everyone who shared a diagnosis of depression in prior problem lists. It's a slightly different comparison than a more heterogeneous mix of people seeking care for a variety of reasons. Or we could have looked at a particular visit as the trigger, perhaps being seen in an emergency department, being seen in a primary care setting, for example, where I practice, or being seen at a mental health outpatient visit. What's the downstream risk of people being seen in those settings as we look forward? And all of these choices are valid, and that's something that I want to define. And the reason it's important to think this through is if you remember your clinical workflow and what your clinical intervention or prevention step might be, it helps you to contextualize these choices. Next, we start to think through the predictors that may help us define these patterns. We use expert knowledge. We use the knowledge of our collaborators on this project. We look to the literature and see what people have done before. And we also have a fairly pragmatic understanding of the data that might be available. A lot of our research falls under the category of something called secondary use, where we have electronic health records collected for other reasons, and we try to use them for things that no one thought of in the first place. So in this case, we opted to choose diagnoses, and I've mentioned some of the challenges in using diagnostic codes. But because they're readily available, there may be some value to using them as potential predictive signal. And the reason they're valuable is because just about any hospital that provides care in an electronic health record system will have these fairly readily available. Similarly, we looked at medications, using medication tables and documented medications that patients had encountered to potentially help us understand the risk. We also looked at visit utilization, and you'll hear a little bit more about this in a subsequent study, where we looked at numbers of outpatient visits, inpatient visits, and emergency room visits. We looked at particular demographics, such as those shown, and we're often in a situation where we care about a particular thing, but we may not have a well-measured feature that defines it in, for example, electronic health records. So we might care about things like socioeconomic status or social support, but we need to be clever and thoughtful about how we might use data that we have to help define them. The one example I'll give is the example of zip code, which we actually mapped to an accepted area deprivation index that came out of a group from Wisconsin that's been important to us in a number of prediction algorithms. Again, an example of the community helping the community. That index ended up being predictive in a number of our studies. And the take home there, again, is sometimes we're in this situation of surrogacy, and that surrogacy in defining a predictor can still end up being important in our data scientific studies. Now, in a high-level view, we take those data that we've carefully prepared, and roughly speaking, I'm going to oversimplify here. We might define it into something like a training set and a testing set. And that training set is where we know the outcome, we have them clearly labeled, we have those input predictors that I've mentioned, and we then feed those to algorithms, perhaps one, perhaps many. I am showing you again a non-comprehensive look at a few of the algorithms that we used in our work. And I want to emphasize that it's important to be empiric here. Each of these algorithms have different expected assumptions. They have different advantages and disadvantages, things like being parametric or non-parametric. Different relationships are expected between predictors for some of these algorithms. So it's important to be agnostic a little bit, I think, in terms of testing these data when you're doing a new problem. And sometimes it's actually combinations of algorithms that end up being really important. And I'll give you one example where that's true. And so we essentially model those outputs, we let the algorithms attempt to predict those labels, and we look at a test set to see how well it did. And I'll talk to you about how we measure that performance in a moment. But we compare it to that testing set where we have new data with censored outcomes, but predictors that are otherwise more or less identical to that in the training set. And that's roughly speaking how we start to test these algorithms. I'll take a moment to describe how we evaluate performance at a fairly high level. There are really, when possible, I subscribe to the idea that there are really three main arms of things we care about. The first is the idea of discrimination. How well do we identify those people who are truly going to have the outcome from those who will not? Second, we think about calibration, and that's this idea that the predictions will hopefully reflect the true prevalence. An easy way to think about that is if I say there's a 10% risk of something downstream, that means that 1 out of 10 people who look like that person in my population should have that outcome. And that's really important, not just for giving good information to those who need to act on it, but also helping us from a decision analytic perspective. We have to contextualize risk to be able to make the right decision. And then finally, I won't talk about this any further other than what I'm about to say. We think through the idea of usefulness. And this paper that I show here is actually in a different domain, the domain of readmission risk, where we try to unpack this decision analytic method to say, a priori, before we put a model into practice, can we estimate what the potential benefits or harms of that model might be in the real world? So now we'll talk about some results of that initial study, and then I'll tell you pretty quickly about some of the studies that followed. First, some results from that initial effort that I showed you before. At the top left, you see a set of receiver operating characteristics. Really, the area under the curves are actually the values that you're seeing here over time to predict the outcome that we care about for a number of different comparisons. A couple of things I want to emphasize. Remember, this is a fairly common metric that you'll see in just about any predictive modeling paper these days. And there are advantages to this metric. There are also disadvantages to this metric. Note that 0.5 is roughly a coin flip. That's as bad as that performance gets. And initially we thought, great, this performance looks good, but I want to triple underline the idea that in a retrospective case control study like this one, it's a very different animal than a prospective evaluation in a more real-world practice. So it's critical to be humble about what these results will really mean in the real world and to commit to testing them prospectively in the future. And that's some of the work that we're doing now. At the bottom right, you see an example of something called a precision and recall curve. Recall is a synonym for sensitivity in this case. And precision is positive predictive value. And particularly in prevention and suicide prevention, precision is very, very important. And there's some wonderful literature growing in this space talking about why precision is so important. The way I'll summarize it is as follows. Think of it as the number of people who get labeled with a particular risk category to capture that one individual who actually has the outcome, which means if you have low precision, you may capture everyone who has the outcome you care about, but you do it at the expense of giving everybody else a high-risk label. And if you're scaling prevention, that can be very difficult to figure out who's truly going to have the outcome that you care about. So we were satisfied enough in that first effort to think that our algorithmic approach might be worth validating further. So what are the subsequent questions that are important to ask in that case? The first question is, well, does this algorithm that we validated internally, does it work in new cohorts, new outcomes, new settings? Does it validate externally? Second, we like to think, how will this maybe be deployed and how will that be evaluated? How does it augment clinical workflow? You know, and I include this point here, but frankly, this is something that people should be thinking about from day one. It's always important to think about where you're going to end up if you're successful in your initial modeling effort. And then, as I've mentioned before, what are the potential benefits and also harms of integrating this type of modeling into practice? And I'll give you some examples of those in a moment. Our first external validation was to look at a different age group. I've emphasized how age differences are really important in this space before. So when we looked at adolescents and we tested our algorithm trained on adults, in this group we saw there were some important differences. First, the performance suffered pretty significantly, so much so that we retrained our algorithm. We reweighted the predictors that we'd chosen for this age group, and it was important that we did that. A lot of the predictors were important in both groups, but the weights were vastly different. For example, in adolescents, attention deficit disorder popped up, whereas in adults that wasn't very important at all. The affective environment and area deprivation was actually much more important in adolescents than it was in adults. In adults, on the other hand, comorbid illness and other medical problems, as well as things like post-traumatic stress disorder, really were important to performance. All that to say, as I said before, one model may not fit all, and it may actually be that a suite of algorithms in practice may be the most important solution for prevention. The next study I'll describe tackled a new cohort. We were interested in studying and partnered with some collaborators that are shown here. At the bottom right, you see Lindsay McKernan, who's a psychologist at Vanderbilt, Matt Leonard, who is a PhD student in my lab in the middle, and Leslie Crawford, who's a rheumatologist also at Vanderbilt. We were interested in studying a particular population that all shared a chronic pain syndrome called fibromyalgia, which we know is enriched for suicidal thoughts and behaviors. We took the algorithms that I described to you prior, and we tested them completely out of the box on this group of patients, around 14,000 people who all shared that diagnosis. And the initial performance, I'm emphasizing discrimination performance here, but again, it's a holistic performance evaluation, was reasonable. But we wanted to do something a little bit further. We wanted to try to explain this performance, to do something a little bit more interpretable, and perhaps think, could this suggest what an intervention might look like? And so we do a lot in that paper talking through some of the risk factors. I'd encourage you to look at it if this sounds interesting to you. But one of the ones I'll unpack now is this idea that we'd seen before, that those individuals seen frequently in an outpatient setting seem to have lower downstream predicted risk of suicide, and we wanted to understand what that meant. So we asked a fairly simple question, but we did it through computational means. We asked, how much more time is spent in clinic for those individuals in this group who never require treatment for suicidal thoughts or behaviors compared to those who have them? And we were fairly blown away by the numbers that followed. For those individuals who required treatment for suicidal thoughts at some point in a year, they were seen on average around 2 hours. For those individuals who never required that treatment, they were seen significantly more, almost threefold more here, 5.9 hours on average. This difference was even more staggering for those with suicidal behaviors, a really drastic fold difference in those who were seen in clinic. And this finding has also been seen by others in this space and has been published by others in this space as well. And so all that to say that these algorithms may have a role not just in predicting those people who might be at risk for suicidal thoughts or behaviors, but there may be some role in identifying those individuals who we have not seen in a while. In my clinic, I often worry about that person that I saw yesterday, but perhaps I'm not thinking about the person that I have not seen in the last year. So something we're studying now is whether these algorithms may have a role in helping us identifying those who may be falling through the cracks. And we're not alone in that finding. And I can talk in the Q&A about some other examples where I've seen this be true as well. So now let's move from prediction into practice. And some of the work that you'll hear at Vanderbilt University currently is really to do that prospective validation that I mentioned, moving out of that retrospective case control to really understand how well do these predictions work in practice using operational systems at Vanderbilt. And this work is partly funded by a wonderful grant from the Evelyn Selby Stead Fund for Innovation grant at Vanderbilt. In parallel with that prospective validation, we're also thinking through the clinical process design, and we're doing that through partnership, working with our stakeholders and our practitioners who are actually seeing the patients in the clinical setting to understand our best current practices and to help enable that prevention. And then we want to move from a civilian hospital like Vanderbilt University Medical Center to a population in active duty. And so this next project that I'll describe to you is a partnership with Lori Novak, who's an anthropologist and an informatician at Vanderbilt, shown on the left there, and then Joe Franklin and Jess Ribeiro, who I've mentioned before, who are shown on the right. And what we're actually doing is porting our approach, defined in civilians, to an active duty service member population. Our first step is to ask the question, how well do those algorithms work if we move them to a very different population, the U.S. Navy active duty service members? So that first step is really a truly data analytic aim. But what I find really exciting about this particular project is our second aim is focused entirely on evaluating the clinical routines and workflows that are at play in the U.S. Navy primary care. We're doing this to inform our decision support, and we're to work with our stakeholders as we are very humble about what might work in this new setting. And so we need to learn from them probably more than they need to learn from us in terms of how to do this properly. And in our final aim, we're going to be piloting our decision support and studying uptake and behaviors of the providers who may be getting our recommendations. We're thinking through what education needs to go along with this, what training may need to accompany it, and how do we solder these types of predictions to the potential interventions and preventive steps that our providers can actually try in this space. So the take home there is that there really is no prevention without partnership. We're already learning Stigma is a problem. We know stigma is a problem in any clinical setting, certainly in mental health and definitely in suicide. In this case, there may be career implications to the stigma of suicide. We need to be very thoughtful about that if we're going to be using algorithms to predict suicide risk and integrating that with electronic health records. Presentation and context are really important. Thinking again, what is the education? What are the other information that we need to provide along with those recommendations? Next, engaging our stakeholders will not only help us design a better tool, it may also help our uptake. Those co-design steps, and there's great literature to support this, often result in tools that are not just better tools, but often tools that are more likely to be used. Now, we're going to move from the hospital environment to the community. And this is a partnership with the Johns Hopkins Center for American Indian Health, which has been really a wonderful collaboration. And this is a community-based suicide surveillance and case management program that we were very thrilled to be engaged by the Hopkins team to start to think through this problem. And what I want to emphasize is in this particular community, there are caseworkers who are providing care and recording data from clinical encounters in the field through structured forms. That's very different than the type of hospital data that I've been talking about up until now. And what's really exciting about this is this becomes a mobile healthcare delivery framework, which is very different than the idea of patients who come to see us in a clinical setting at the hospital. And so part of this surveillance system includes mandated reporting for concerning behaviors, such as suicidal thoughts, binge drinking, self-injurious behaviors, and others that you see here. I want to emphasize again, there was no routine hospital data here, only what's collected by those caseworkers. So the challenge before us was, can we use the form data that's being collected routinely to try to predict those people who would be downstream risk of suicide attempts or suicide death? So I'll say in brief that we felt that the internal validation here of our predictive models of suicide attempts or death at 2 years was reasonable to work a little bit further. And again, as I said before, that's really one of the very first steps. What we're thinking through now is how do we refine and in fact simplify those algorithms to make sure that we have the optimal chance of implementing them in a successful way. And our current work now is actually to understand how to build the most interpretable algorithms that simply will work in practice in a mobile healthcare system that is in the field, that is sometimes offline, and needs to be interpretable. And the reason that point is so important, when I say interpretable, it means not just that we might make a recommendation, but that we can unpack exactly how we got there, or as best we can, how we got there. The reason that's important is it, one, helps us act on those recommendations. It helps us build trust with our partners in terms of how we get to a recommendation that we give. And then really importantly, these models will, with some frequency, be wrong. And having interpretable models will help us to some degree figure out why that might be true. So the take home here is that strong collaboration often matters more than the best algorithm. So I'll take a few minutes to talk about some of the grand challenges that underline this work, not just our work, but the work of others in this field. The first, the data analytic challenges in this space. That first challenge, causal inference, is something I want to underline. The statistics you've heard about so far and the findings I've described have primarily been strong correlation. Those correlations may suggest steps to us, they may suggest prevention, but they do not suggest causation. That's a different experimental setup, and it's important to bear that in mind. The second grand challenge is time and temporality, thinking through how we better use time to make a better prediction, how we best intervene in terms of risk. So imminent risk versus more distal risk in suicide prevention is really critical to think through. We're just scratching the surface on problems like that. Lastly, and I emphasized this a little bit before, this idea that how do we work with algorithms that may, out of the box, have fairly low precision? Because suicidal thoughts and behaviors are inherently still relatively rare events, though they're extraordinarily high stakes, and we're doing our best to prevent them. We are tackling those challenges now, just as others are around the world. There are some important clinical challenges to emphasize in this space. I alluded to this idea of usefulness, but really what we're interested in is clinical effectiveness. And in getting to that, it's going to take really rigorous study, and we're just scratching the surface on that as well. And there are others who've been at this a little bit longer than we are. We're all talking closely, trying to learn from each other about how we do this best. How do we best engage patients and their loved ones, those who've experienced this tragic event of suicidal thoughts or behaviors, or worse, death from suicide in their lives? How do we best engage patients and their loved ones to learn from that and to design better preventive strategies? How do we contextualize our predictions into effective prevention? And as I mentioned, how do we avoid worsening stigma in an area where stigma is a real problem? Partly how we get there is through transparency, partly how we get there is through conversations like the one we're having today, where we shine a light on how challenging these problems really are. Some of you may be thinking, well, with all this data sharing, there are real privacy concerns, and I would agree with you. And so this is just one example of a rich literature around privacy and protecting privacy, especially in the space of mental health and data sharing. And we talked just a little bit about some of the potential controls that can be brought to bear to try to prevent data breach, try to prevent misuse of data, and often unintentional harm even from the best intended study, where data is shared in a way where it potentially could be re-identified, for example. So I won't have time to talk about that in great detail, but I do want to emphasize that privacy is a big issue, but we have to think through how we can protect privacy, but still make progress with prevention. And along those same lines, we're thinking a lot about ethical implications of this work, and we're not alone in that. There are actually a number of really interesting papers that have come out even in the last month in this space, and I'm just showing you one example out of our group, where we're thinking through how we can protect life while we're also preserving the liberty interest of those individuals involved. I'll show you the table from this paper, which is an open access paper that is readily available to you. I will not attempt to go into great detail in terms of this particular chart, but our recommendations, at least in terms of this space, include a couple of different arms: consent, controls, as well as communication. And a lot of our attempt is really to encourage further conversation with those who are thinking about these problem spaces, to think through what are our obligations to our patients, to our providers, to everyone who's involved in this complex space. So our take-homes here: to get from prediction to prevention strategies, we think there's a role to combine data science, potentially with some explanatory approaches to suggest intervention that may actually help our uptake. As I've said before, really critical to this success is collaboration, partnership, and conversation and communication about how hard this really is, but not being unwilling to make some steps to try to make a difference while we partner with our stakeholders to integrate some of these technologies. So we're seeing more and more scalable, robust models that have potentially great reach. There are unprecedented quantities and combinations of data that are now available, as well as unprecedented willingness for the cross-cutting collaboration, some of which you've heard described today. However, as with most good research, there are many more unanswered questions on how these tools will really integrate optimally, never perfectly, into practice. And the only way we get there is through measured, cautious science and being willing to evaluate our steps as we integrate them into clinical practice. There are a number of limitations to highlight here. First off, there are a number of biases that always are brought to bear here. For example, sampling bias. For example, we defined our cohort at Vanderbilt University Medical Center in our inaugural effort. There's many other ways we could have thought to do that, and we've seen other groups do this differently, and we try to learn from those efforts as well. There are clinical biases, the idea that, I put on my primary care provider hat and I might decide I know the best way to solve a problem. It's really critical in data science to be humble and to be a very cautious and good listener to those who really know the space that you're trying to tackle. There are anchoring biases where we make a decision a couple of years ago that may be useful to a model back then, and then we need to be willing to question those assumptions as we move forward, to always be striving to do a better job. Once we've published an algorithm, it's tempting to want to use that in a number of spaces. And so again, it's important to always be willing to be empiric and reevaluate those choices in new settings. There was a bias in my talk here around supervised learning, the idea that we started with labeled outcomes, really carefully curated and labeled outcomes, something called supervised learning, but there's an entire class of methods that are more unsupervised. The idea that from complex data, we may be able to discover patterns that teach us something new, that teach us answers to questions we didn't even know we had. And I think there's great role for that in this space as well. And I want to be really transparent with you that we emphasize one particular approach and not at the intent of excluding the other. Finally, the last limitation I'll mention is we often rely on secondary use. As I said before, we have electronic health record data, and we will use that to define some of these algorithms. But the way I'd summarize that is that may be the data that we have, but is it the data that we need? And I'm happy to talk more about that in Q&A. Where we are now is really partnering some of the work that you've heard about so far to really trial these prevention strategies in practice, which is really making these predictions useful. Secondly, we're trying to optimize decision support around these types of predictive tools. We sometimes summarize that as the 5 rights. Getting all of those rights proper for this type of a study ends up being really important to make sure that our decision support may be effective in practice. Now we're asking questions about how we might integrate novel data streams into clinical prevention. Something I hear a lot about and get a lot of questions about are things like social media, messaging data. Clinical narrative is something we're actually spending some time. Clinical text and things, the notes that are written. How do we use those novel data streams in prevention? Genetics, something I didn't have a lot of time to talk about today, but could talk a little bit about in Q&A. We have a recent study that came out where we used our clinical predictive algorithms to define a phenotype to encourage genetic analyses. And now that we're able to do that, we have to ask the question, how is that useful for clinical prevention? Is it useful for clinical prevention? There are many more questions that we're asking today, and I look forward to hearing some of your thoughts as well as having some discussion in our question and answer. I'll emphasize some of the teams that I've emphasized in particular in these acknowledgments, the groups at Vanderbilt who've been wonderful, my partners at Florida State, at Hopkins, and in the Navy on some of the projects that you've heard about. And I want to take a moment to thank the extraordinary number of people who've contributed to some of the work that you've heard about today, and taking a moment to do that here, as well as those funding sources from a variety of sources that have helped catalyze our work to the state that it's in today. With that, I will thank you, and I'm happy to take questions.
Thank you, Dr. Walsh. Very interesting presentation, interesting methods. We have a number of questions related to the difference between prediction and prevention. If I were to try to summarize some of these in general, people are noting that what you're talking about or what you're presenting seems to be methods to predict who might try to attempt suicide in the future, or who might have suicidal ideation in the future. And identification of those at risk is certainly a first step, but it's not in and of itself prevention. And so the question is, what happens after you've identified someone that your algorithm tells you is at high risk? Mm-hmm. So let me pause and get your thoughts.
Absolutely, and great question. And I hope to emphasize that difference to some degree, and I'm thrilled that the audience is also curious to hear more about that. So I can give you an example from our work, our current work, for example, at Vanderbilt University. So if we're able to add some predictive understanding to who might be at risk, we ask the question, well, what do we do with that? So one of the questions becomes, in what context are we going to make that prediction? What's the clinical setting at which we may be able to act? If we're going to, for example, float a prediction to providers, we need to make choices around who actually will see that information, on which patients will that information be made available, and what other data will come along with it. So one of the angles that we're very much working in is built off that study that I referenced prior. The idea that we may want to intersect a predictive algorithm that looks at risk of suicidal behavior, for example, in the next month or the next year, and we want to intersect that with an algorithm that's listening and watching to see who might be showing up. So for example, an outreach effort in primary care in my clinic, for example, may be something where we get that panel given to us where we can see those patients who are not just at risk, but who have not shown up in some period of time. So there's a great example, for example, the ReachFed effort at Veterans Affairs has prioritized the very highest percentage of risk to inform similar outreach, to try to find those people who may have fallen through the cracks, to identify those at the very highest risk. And it may be a phone call to that individual. There's a really interesting study from a few years ago where a preventive effort involved postcards being sent to patients, and there was no efferent arm to bring them back. So there was a card sent from a group basically saying that they were thinking about that patient, how they were doing. And in that population, they found that those cards alone actually seem to be associated with lower rates of behaviors. So we think that informing outreach is actually one of the areas we're working most specifically. So we're using prediction, however, to direct outreach. So in my clinic, for example, if I have 300 or 400 patients that I'm thinking about, I now have an ability to potentially prioritize those individuals in my panel and who I may want to follow up with the most. And if I then cross-link that with those individuals who I may not have had any contact with in some period of time, that helps me now prioritize my preventive effort to reach out to those individuals. And so the clinical process design that I mentioned has to go along with it. And so it's part of the discovery work. The implementation science is just as important as the data science, and only in that combination do we actually get to prevention.
Right. The identification of people at risk, as I said, critically important. Knowing where that's happening and who can see it creates opportunity for different kinds of intervention using those channels. But you still got to have some intervention content. Reaching out to people, encouraging them to come in is one option, but I'm sure that there are other things, and time will tell us which of those strategies are more effective than others.
Absolutely.
We have some technical questions, not surprising given the technical nature of some of the presentation. What is the impact of undercoding on risk prediction when the cases are defined based on, say, an ICD diagnosis?
Yeah, so for example, this project I can tell you a little bit more about, where there's actually two aspects of it. So let me simplify for a second in an attempt to answer this. Undercoding may actually affect the outcome definition, and I've given you an example where that's true. It also might affect those predictors that we're using to predict downstream risk. And so, for example, what we're working on right now is even a better algorithm to identify those new cases that have come in since the time that we did that initial validation, to make sure that we're not missing cases of suicide attempt that are being treated at Vanderbilt, or suicidal thoughts that may be treated at Vanderbilt that we haven't identified since our initial validation, right? Chart review was really important in our first step, but it's difficult to scale that, and it's also difficult to do that prospectively. So one of the elements that we're actually spending some time in is using notes and using natural language, and so we've partnered with some of our experts in natural language processing at Vanderbilt to actually start to understand how we can best survey data as it comes in to identify even just the cases of the outcomes that we care about. So the evaluation won't be effective if we can't identify those new cases of suicidal thoughts or behaviors in our charts. We're going to have a very difficult time doing the prospective evaluation that I described to you. And that's in the case of the outcome. One might argue that if we're delving into clinical text, we'd want to use that for prediction as well. And we think that may be important, but one of the challenges with using clinical text in operations, especially for prediction, is the feasibility is just a little bit more difficult, and it's more difficult to scale. It takes a really sophisticated operation to be able to do that in real time and to do that prospectively. So it's not off the table, but we want to make sure that it's really worth the lift in order to get there. So that's just a couple of elements in which this is really difficult. The last thing I'll say about it is one of the findings that we found is even when things aren't coded as frequently, we often are finding that there may be variables that capture that in a more latent way. And the example that often comes from some of our earlier work is this idea that sleep disorders, and there's a great literature to support that sleep disorders contribute in some way to suicidality. And there's some great evidence that we've found in our studies that there are surrogates for sleep disorders. Even if sleep disorder itself is not coded, things like the medications that may be prescribed for a sleep disorder, some of the other diagnoses that may be coded and not necessarily as intended to be a surrogate for sleep disorder, but there may be other symptoms that when looked at in combination, certainly along with some of the medications that come along with that, all of that comes with, for example, things like melatonin receptor agonism is something that we were quite surprised to see was important for prediction. But when I'm talking about things like that in my clinic, it's because I'm talking about sleep. And note, I'm not saying whether that's a risk or a protective factor here. I'm saying simply conversation about that, that ending up in somebody's medical record ended up being important to help us predict risk. So even when things are undercoded, when we've got really complex amounts of large amounts of data, we're actually finding that there are some surrogates, again, for the thing that we actually care about that we can find in the data. And that's, I think, one of the strengths of the machine learning methods that are able to handle larger and larger combinations of data.
Thank you. We also have a question about overfitting. So perhaps you could talk a little bit about what overfitting your algorithms mean, and then tell us what methods you use to avoid it.
Absolutely. And let me see if I can get to a slide for you here in my supplement. So there's a few ways to talk about this, and I'll just end up on this slide here. I didn't have a lot of time to talk about it in the initial talk, so I'll talk about it here. Model fit is something that those of us who spend time doing model development worry a lot about. And the types of studies you've heard about, ours are examples of this as well, and we're very open about that, especially as we're using more larger and larger combinations of predictors. We're talking hundreds or even thousands of predictors, especially with rare outcomes like we're discussing. And sometimes our cohorts may be thousands of patients, maybe tens of thousands, maybe hundreds of thousands. The idea of model fit, overfitting, essentially the way I'd summarize it is I told you a little bit about training and testing. But one of the ideas here is if you train a model to perfectly identify the patterns that it sees in training, and then you move into a test setting and you see that the model performance completely falls apart. That's a really good example of overfitting. And the downside of machine learning and some of the studies that you're seeing as we have more and more data at our fingertips, it's actually almost easier to come up with a model that's actually overfit than the alternative. You might ask, well, what is underfitting? And so the way I tend to summarize this is those relatively, those clinical risk scores that some of you might be familiar with that are the kinds of things that have either a short acronym or maybe 4 or 5 predictors. Those may actually be underfit, which means that they underdescribe a little bit of the patterns that we see in the training set as well as in the testing set. The reason you tend to see more underfit models in clinical use is because they're really, really easy to implement and they tend to be easy to share. And there's value to acknowledging model fit being such an important issue. Acknowledging that the more novel methods, the papers you're seeing in more recent years, when you see machine learning and you're seeing hundreds or thousands of predictors, you want to have a very high bar to watch for overfitting. And it's partly the reason that external validation is so important, because the ultimate test for model fit is to test that model in a completely new setting in order to avoid it. So to summarize, the studies you've heard about are more prone to overfitting. And what that means is we move out of a training environment into a new environment, and we see that the model performance is not nearly as good as we saw in model training. So it's a really key issue, and thank you for that question. It's something that we worry quite a lot about in this space.
I suppose if you're successful in predicting the people that are at highest risk, and you're working with collaborators who are really good at intervening, and they then actually make headway and prevent those people from engaging in the behavior that you're trying to prevent, that and you kept doing that for a while, your algorithm would eventually quit working. I suppose that's too far-fetched to be a real-world problem, but is it something that you think about?
We are actively having conversations about that. So the idea that, if we're successful, if we integrate predictions into clinical practice, we're able to better target intervention and prevention. We actually almost become our own confounder, for lack of a better way to describe that. And so we actually in the last week have been having conversations with other people who are experts in this field, trying to think through how you account for issues like that going forward. It's almost a problem you want to have. You want to see that your algorithm is so successful at targeting prevention, for example, that you move the needle on the outcome to the point where you need to now consider how you actually take that into account. And there's a number of methods. There are some statistical methods we're looking at, and also ways of potentially trying to measure that effect. It's actually by no means something that we're not worried about in the real world. It's probably going to be something that we're going to be worrying about a lot more. And it's not just true for suicide prevention. It's true in general as we're integrating more knowledge insight. So one of the other grand challenges I haven't emphasized is how we assess the effect of new knowledge or information being provided to people when we don't necessarily we don't presume that changing workflow is easy. It's actually much, much harder than often a lot of the modeling work. So if we come out and say, we've got a new predictive algorithm, we're just going to give this to you and we think we've solved your problems, I think we're making a mistake. It's really important to partner in that sense, as you spoke to pair that with meaningful intervention and prevention. And if we think a new intervention or preventive step is necessary, understanding that is not for the faint of heart, and it's something we want to make sure we design in a really careful way.
A general question about working with test sets. How do you evaluate the performance of the algorithm in the test set if you don't know, you don't have the outcome for the people in the test set? It's a new set, of, and maybe it's not. Maybe you wouldn't even call it a test set. Maybe you'd call that a novel set. But how do you know whether the algorithm is being predictive, being accurate in that new sample?
Great question. And so this is something I want to make sure I clarify, especially in the retrospective studies. And that's typically where we start. We might start with data that we have because we want to test an algorithm that we would eventually use prospectively with a similar data stream. In that test set, retrospectively, we do know the outcome, but we do not give that outcome to the model. So we let the model learn from training data. Then we let the model attempt to make those same predictions on a novel set that it hasn't seen before. However, we, the designers, know the answer, and it's by comparing that answer to the model's best guess that we evaluate its performance. When we move into the prospective realm, which is where we are currently, We need to be really careful about evaluating and surveying the data streams that are coming in to make sure, as I mentioned before, we're not missing those cases that will help us evaluate model performance. And it's that latter step that's most important, that latter step that's more difficult, but it's actually important to do both.
You mentioned a phrase earlier about people falling through the cracks, and that was in the context of people who don't come in as often are at greater risk for suicide attempt or perhaps suicide ideation. The falling through the cracks phrase is something that we hear in the general media on a regular basis with reference to people, for example, who commit violent acts against others. That's a very different kind of thing than suicide. But it makes me wonder, would methods like this be applicable in that kind of circumstance?
So my first response to that is, it's easy when you're a methodologist and you think about a suite of methods. It's easy to again, that age-old analogy, the hammer and the nail, to say, well, if I think a lot about machine learning, I'm going to find a way to use machine learning for just about every problem. There are problems where it is well suited. There are problems where it isn't. We could probably imagine, even in the course of our discussion, how we might set up an experiment to test something like you described. And I think that's why it's always really important to remember, even if we set out to do some modeling, how might that be useful? The problem we had at Vanderbilt, and why, going back to this idea of prediction versus prevention, the prediction problem, the identification problem was so significant that we really needed to spend the time to try to do that as well as we could in order to enable prevention. So, for example, I've done some analyses looking at routine clinical screening. And there's evidence in some recent papers that have come out showing that, for example, in an emergency room setting, the ED-SAFE study, where universal screening for suicidal thinking was associated with follow-up, with patients being followed up with after an emergency room visit, there was a change in suicidal behaviors over time, which is a really exciting result. And so what we're hoping to do is, how do we augment or make screening easier? How do we help direct who even should be screened if we're going to rely on the wonderful face-to-face clinical instruments that we've used for years? We may even want to direct that effort, because that effort takes time and it takes effort as well. So, it may be that if you're looking at a complex problem with complex data sources that you have access to, it may be worth thinking about a predictive analytics study that, for the example that you gave. But I think it's always important to remember, if we think we can predict something, now what are we going to do with that? You have to think about that from day one. Because if you can see an intervention where identification is a big problem, and that's what we saw in our initial work, then I think that's a really great example where these methods might apply.
Related to that, we have a couple of questions about privacy/legal issues related to both false positives and false negatives.
Sure. So there's a lot there. So I won't necessarily be able to get to all the nuance that might have been behind some of those questions. With respect to the data that we're using, one of the questions we get a lot from a legal perspective, are we worried about using the data, for example, in the projects at Vanderbilt? And one of the things I want to emphasize is we're not using any data that is not included in an electronic health record already or collected through routine care in any of our studies. And we make sure that we get institutional review board permission for everything that we've done. And I think something that's more on the cutting edge, and the conversation we're trying to have now, is what are our responsibilities around transparency and communication about what we can do. So, for example, we've been using risk scores for things like prognosticating risk of high cholesterol for years. Sometimes we use that to make treatment decisions, to decide whether or not to start a statin. And so I'll use data from a patient's chart to get some a risk score for that. And then what do I do with it? Well, I use that in a shared decision-making model with my patients to say, this is a new piece of information. We want to share that with you. Let's make a decision based on your preferences and values and everything else about what we're going to do and how we're going to proceed. And also making clear that just this number is not the patient. We want to treat our patients. We don't want to treat numbers. So this is a more fraught environment now that we're talking about things like suicide risk, something that we're attempting to predict more and more in the last few years. But some of those analogies, I think, still hold true. So I think it's important to be transparent about the data that's going into these models. And so in our example, it's all the data we're collecting routinely anyway, and not bringing any new data that we don't already collect from our patients as they come in to see us. And we're not taking any of those data out of the context of the patient chart, except to do that prediction, to give that right back to the provider, again, in the context of the patient chart. And so it's also, the last thing I'll say about this, as we're doing all that, is to be really upfront about what we're trying to do, and to be really transparent about the fact that this is relatively relatively novel, at least for this particular problem, and that we will be wrong, as I said before, with some frequency, and we hope to learn from those events. One of the questions I get a lot is, well, what do you do if the provider has one sense of someone's risk and the algorithm comes out with a risk prediction that surprises the provider? We're hoping to learn from those events. We're hoping to be really clear that we know that will happen with some frequency, and how do we actually best leverage the fact that we have providers who are brilliant at what they do and have incredible insight and ability to understand nuance, which is something that algorithms simply are just not going to be as good at. So how do we learn from that difference?
You're working at Vanderbilt, and you've got a sizable database in terms of electronic health records. But as you noted, you're working with events that are fairly rare. What if you wanted to try to partner and combine data from Vanderbilt with data from Northwestern or data from Mass General? How do you harmonize the data across different sites so that you can use it in this kind of work?
Yes, great question. And so, to really, I think certainly in our hospital, and to get to the point where we can really run a good pragmatic trial, for example, is one potential study design where we might really study these interventions and these preventive strategies in practice. We know we're going to need to partner because it's going to take too long for us to be powered to really measure that difference. So the way we get there, there's actually a number of ways we get there. One is whether we partner as part of a network. The mental health research network is a great example of that. It's about, I might be wrong on this, so I think it's about 15 healthcare systems that have partnered and actually have data. And so there may actually be a data pooling effort. The way you harmonize data in an effort like that is you agree on a data model. So you agree to represent hospital data with respect to a particular data model that everyone shares. And so then we can more easily actually pool data together. However, we're also thinking through, and we have a couple of examples of projects I haven't mentioned, where we're doing a step where we're actually managing to partner, where we may not actually need to pick up and port data in order to learn from each other. So, for example, we have a wonderful effort as part of the eMERGE network, something called Psych eMERGE, where we're looking at important mental health phenotypes like bipolar disorder and others, where we're actually partnering by having regular conversations about the science we're doing. We're sharing algorithms, and we're running those algorithms, not the actual data, but the actual weights on the coefficients, where we can actually run those algorithms across different data sets without moving data. There's actually, the last thing I'll say about this, there's a growing body of literature that's really exciting in this concept of distributed analytics. And the idea behind that is that you can imagine data, for lack of a better analogy, imagine data within the silo of a hospital system. And imagine another hospital system that has a similar silo of data. But there are some means by which you can actually, without moving data, without learning from and having to actually share data directly and sending it to someone else, where you can actually distribute the analytics themselves in order to build a better algorithm from all of those data. So there's a lot of exciting work being done in that space that I think we're going to continue to see evolve over the next few years.
All right. I have a question which I claim no understanding, so I'm going to try this on you and see if you can help
Okay.
me and the audience. You mentioned undercoding and underreporting can affect prediction of risk, but can this lead to a sort of length of time bias towards those patients that are long-term sufferers or those whose risk is generally easier to detect?
Be thoughtful about that question for a moment, because I do want to try and hone in on what I think it might be about.
Yeah, I was trying to be thoughtful about it, but I didn't get very far.
So I think, the patterns we tend to see in data where there is historical documentation of things, and we're actually doing this work currently for a proposal that we're working on, where we're trying to identify historical suicide attempts or historical suicide ideation, which is actually something that's also not coded. If I see a particular patient that 10 years ago might have had a suicide attempt, that might not be something I code again 10 years later if that is something that's been fully treated, and this idea that someone comes out without evidence of suicidality for the last 10 years. So I do think, I guess with respect to one aspect of that question, the idea that our model is going to penalize people who are historically reporting their symptoms. We certainly don't want to discourage people from reporting symptoms by then giving them predictions that affect their risk profile, or something that comes up in a chart every time that person shows up when they've gotten proper treatment and they're in a different place now. We need to be really thoughtful about the fact that people will go in and out of illness states just like they do in mental health, just like they do in other areas as well. So I do think it's important. I do think there is a risk of bias. And this may be what that person asking the question was about. There is potentially a risk of bias around the idea that if there's a historical behavior that was reported or documented, will that change the person's risk profile? We don't want to penalize that person for the rest of their lives, that they're always in a particular risk category and we never let them have a chance to have that change. To get there, we have to acknowledge that that's a really difficult modeling problem, and we need to do a better job of dealing with time. So I think we need to, one, acknowledge that issue, and I think that question might be getting toward that. And then we need to think through better methods to really take into account that time, that as time varies in a chart, we're doing fairly blunt things right now to somewhat cross-sectionalize time and make time a little easier to deal with. Treat it as a little bit more stationary than it really is. And so I think we need better methods to handle those changes in time. So if that's what that question was about, hopefully I spoke to it a little bit. I think it's actually a really hard problem.
Thanks very much, Dr. Walsh. I'll turn things over to Marie to close our session.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. As I mentioned at the beginning of the webinar, we will be posting the slides and a recording of today's session on our website next week. You'll receive an email with a link to the recording when it is available. Thank you.